Hello, I'm Cindy Braden, SVP of Sales for EnsoData. Thank you for joining us today in our presentation, The Role of Artificial Intelligence in Navigating Today's Greatest Challenges in Sleep Medicine. We really appreciate having the opportunity to speak to you during the event. There will be a three-part presentation followed by time for Q&A. Since we do have three topics and three different presenters, and there's going to be Q&A at the very end of all three of those. It might be useful if you do have questions, because we want to open this up to be very interactive, to write those down as we go along, just in case another great idea comes up during the second or the third presenter. Okay, let's go ahead and get started. Today's agenda. First, we're going to start off with Chris Fernandez, who is the CEO and co-founder of EnsoData, the company that I work for. As a bit of an overview, EnsoData's product EnsoSleep is artificial intelligence that does scoring of the sleep tests, both the PSGs and HSTs. So we have a lot of experience in the sleep field. We have a lot of experience with artificial intelligence as well. Chris is going to start off today by introducing AI for sleep medicine, from patient care to sleep science. Chris is going to be followed up by Andrea Ramberg. She is our clinical informaticist at EnsoData, so she's an RPSGT. She has tons of experience with patients, working in health systems, private labs, working at night, working during the day, and she's going to be delivering the topic of the expanding role of the sleep technologist. I'm looking very forward to hearing that from Andrea. And then I am going to wrap up with how EnsoSleep, our particular product, I will have the shortest part of the presentation, but how EnsoSleep, the AI-assisted sleep scoring, can help overcome some of today's greatest challenges in sleep medicine. And then we will have Q&A. With that, I'm going to hand it over to Chris to get things started.
Thank you, Cindy, for the wonderful introduction. And hello, everyone virtually. Again, my name is Chris Fernandez, and the title of my talk today is An Introduction to AI for Sleep Medicine, from Patient Care to Sleep Science. We have 5 major learning objectives for this talk today. First, to explore sleep's impact and relevance on major health issues. Second, to define artificial intelligence and machine learning from first principles. Third, to give some current examples of AI in healthcare and in sleep specifically. Fourth, to explore why AI technology is such a good fit for sleep and sleep medicine. And finally, to give some current examples of clinical applications of artificial intelligence with the example of AI for scoring. Let's dive in. So let's dive in on sleep's impact and relevance to major health issues. Sleep apnea is a global public health crisis today. Researchers estimate that more than 52 million adults in North America currently suffer from sleep apnea, and more than 1 billion patients globally. Similarly, based on the latest epidemiologic estimates, those show that currently 80 to 90% of OSA patients are undiagnosed and untreated today. Sleep medicine has its roots in technology starting in the 1970s and is one of our youngest branches of medicine. We are only really at the beginning of our understanding of the role and the influence of sleep and sleep apnea on human health and disease. From what we've learned so far, one thing is very clear. When we look at the major chronic comorbid conditions, sleep apnea is consistently at the scene of the crime. Some studies have shown more than 40% of OSA patients have 4 or more concurrent comorbidities. These patients on average have poorer outcomes, higher rates of mortality, lower rates of survival, and higher healthcare utilization, with those costs driven by increased hospital admissions, ER visits, and higher medication usage. The good news is that treating sleep apnea effectively mitigates these outcome risks and these costs. However, sleep apnea is highly prevalent in chronic comorbid patients. Prevalence estimates include 71% of patients with diabetes have concurrent OSA, with treatment delivering a 4% reduction in HbA1c levels, 15% of patients with COPD, and an 88% reduction in hospital admissions. 83% of patients with hypertension, 58% fewer hospitalizations annually if treated, and 17% of patients were able to utilize fewer medications with their treatment of OSA. These are not cherry-picked results. The results are strong. Other studies have shown a reduction in blood pressure by 41%, fewer medications, improved HbA1c, improved respiratory function, and lower heart disease and heart attack risk in patients with effectively treated OSA. As we can see, sleep apnea is one of the most significant problems facing our global healthcare system today. The condition is one of the most, if not the most, undiagnosed condition globally, but treatment can provide transformative impact to patient quality of life, health outcomes, and healthcare utilization as well. So what is artificial intelligence and how can it help? At a high level, artificial intelligence is a collection of theoretical tools and computer programs that address complex reasoning, problem solving, knowledge representation in terms of how we represent information, strategic planning, learning, understanding natural language, machine perception, robotics, effective computing, and artificial and general intelligence, which is kind of the holy grail of artificial intelligence. So there's two things that I'd like to point out there. First is that AI is not new. AI is a subfield of computer science that has its foundations back in the 1950s. AI is a field that's had many booms and busts as it goes over the years, with high points in its early golden years from 1950 to 1974, a rapid rise of adoption in the late 1980s, and finally, the explosion of machine learning that started in the 1990s as we had the kind of the data-driven revolution with the advent of the web and the critical mass of digital data, including healthcare, electronic medical records, physiologic waveform data, and more. The second thing I'd like to point out is that since its inception in the 1950s, AI has come a really long way. Games have been a very popular way to study and to validate the performance of AI in increasingly complex tasks, to understand its ability to emulate complex decision-making and even visual pattern recognition and perceptual reasoning that we rely on for decision-making as experts. Since then, over time, AI has demonstrated superhuman accuracy in a variety of games, including checkers, tic-tac-toe, backgammon, chess, Netflix recommendations, image recognition, schizophrenia and seizure detection, Jeopardy, facial recognition, understanding comedy, and most recently, in the game of Go. Despite all of this progress, games are very different from the real world. They represent a very controlled, fixed environment where one can play within the rules and learn what works. In order to learn and to facilitate complex decision-making in the real world, especially in healthcare, we need robust methods. In summary, the class of methods within AI itself is much broader than machine learning. However, machine learning has become an extremely popular kind of go-to method within AI because of its ability to learn from real-world data and to be successful in those real-world environments beyond the control and the constraint of games. So what is machine learning? Machine learning is based on the development of computer program methods that learn and adapt to improve their performance in some sense over time given experience. Now, the most common form of experience to feed into a machine learning algorithm is, of course, historical data. That allows the algorithm to, in a sense, iteratively run through that historical data in order to train a model to facilitate some kind of task in an automated way that is represented in that data. In sleep medicine, there is a significant opportunity to leverage existing and novel data methods to study new clinical and research questions. What kind of data are we talking about? Well, really any kind of data under the sun. This data that could be used for machine learning and AI development, research, and clinical applications includes data such as the stop bang questionnaire and other patient-reported health outcomes, wearable data, in-clinic and at-home physiologic data like the PSG and the HST, genomic, proteomic, and other novel forms of omic data, imaging data, and more. So really, it's a blue sky in terms of what data you can use and test out for new applications of artificial intelligence and machine learning. So What are some examples of artificial intelligence in healthcare? We've talked about models, we've talked about data. Let's dig into some good examples. Beyond sleep medicine, AI has been adopted for a variety of use cases. Three examples include predicting sepsis onset in the critical care setting. Sepsis is one of the highest mortality conditions, and early detection can enable intervention that can be life-saving and prevent multiple organ system failure. The second is in skin cancer imaging. So there's a significant lack of access to dermatological services, locality, cost, other factors, and the ability to utilize a smartphone and other mobile technology supported by algorithms can make the screening for skin-based cancers a lot more prevalent. Third is in applying advanced analysis to audio data to be able to help provide surveillance for the COVID-19 spread and the kind of the pandemic kind of tracking factors. Beyond critical care medicine, dermatology, and infectious diseases, AI and machine learning is being adopted in nearly every specialty of medicine for diagnostic, therapeutic, and different research questions. We can give some concrete examples from sleep as well, highlighting three of our prior publications. The first we call computational phenotyping with PSG. So we studied the ability to analyze PSG and instead of predicting sepsis, to predict different adverse health outcomes based on that physiologic sleep data. This is a receiver operating characteristic showing that we can accurately predict 5-year all-cause mortality based on factors contained within the PSG. And not only that, but information from sleep can be as or even more predictive than variables that are commonly understood to associate with adverse health outcomes like high blood pressure or high cholesterol. Second, that AI can help us to deliver and to enable a more predictive, proactive, and preventative approach to engaging with patients on CPAP and to behaviorally intervening with them to improve CPAP adherence. CPAP adherence remains a major challenge today, and AI has been shown to be able to accurately forecast CPAP usage in terms of hours in the next month to enable greater prioritization and resource allocation in a world where there are so many patients out there that we can help. And third, the ability to apply AI to find novel types of information in data. In one of our recent studies, we showed the ability for AI to accurately determine the patient's age based on EEG data specifically. Now, what was interesting about that, and maybe intuitive on further glance, is that when you compare the ability for AI to find an age from the EEG to that from images, the EEG is actually a lot more accurate. And I think what this suggests is that there's really a lot of untapped and hidden potential in the information that we're routinely collecting in sleep, and that AI and machine learning can help us to unlock and to unsurface some of the information that's hidden beneath these medical waveforms. So we've covered a few examples on where and how AI is being applied to advance sort of the fundamental science of sleep and sleep medicine, but it has a broad class of clinical applications today as well. Those include preventative applications that are being used clinically, the opportunity for sleep as a vital sign in primary care to promote greater awareness of sleep, the incorporation of omics, data for disorder screening and novel forms of data, increased diagnostic support with analysis tools for new and existing modalities, clinical applications of phenotyping, and the ability to enhance home sleep testing reliability, and also therapeutic applications, the ability to help to power personalized and precision medicine pathways that we envision, and to validate new ways of monitoring adherence and supporting patients behaviorally and with the right care for the right patient at the right time. We've covered a broad set of examples, so let's focus in from here forwards on where AI is actually being used clinically to aid clinicians in patient care today, focusing on the application of AI scoring. AI adoption has been growing in healthcare broadly. This is a 2020 graphic from Nature's Journal of Digital Medicine, and it shows a systematic review of the US FDA-cleared artificial intelligence software for medical applications today. But that's us, second from the top. EnsoSleep represents, to the best of our knowledge, the first application of artificial intelligence and machine learning that was cleared by the FDA to aid clinicians in scoring in-clinic and at-home sleep studies. Most recently, we obtained our second US FDA clearance this June in 2021, and our Canada clearance this July. Why is AI such a good fit for sleep? Well, there's a couple of factors, both the prevalence of patients and the prevalence of data. Researchers estimate, as we covered, between 1 in 4 and 1 in 12 patients suffer from OSA, and 80% undiagnosed and untreated today. So there's a significant need and opportunity to dramatically increase patient access to diagnosis and therapy. And that may be well beyond the capacity that our current healthcare system and our current way of procedures can scale today. The second is the size of the data. Sleep studies include millions of data points from dozens of sensors. We look at hundreds of patients of data, looking for dozens of complex physiologic patterns that we mark, annotate, and then finally analyze to be able to correctly and accurately diagnose a patient with sleep apnea. This is a very intensive and involved process. And in a problem space where there's such a great need to increase capacity, AI and machine learning presents a promising opportunity to help to support that objective. But this is not new. We've all seen automated scoring and scoring assistive technology. We've all tried it. We've all had a variable experience. So what's different about AI such that it can finally approach this problem and unlock sort of the true promise of efficiency that technology sought to provide and to contribute to the process? To explore the difference between AI scoring and the traditional historic approach to developing automated scoring technology, let's start by looking at the former process. So in terms of auto scoring, this is sort of like machine learning, but instead of utilizing a large database of historical data and algorithms that can learn from that data over time, it is a fully hand-coded approach. In that way, we create if-then statements and algorithms and manually try to encode for all of the natural variability that we see in sleep data. This includes sources of variability from intra and intranight variability, different digital and electrical characteristics from devices, variable signal and dynamic noise conditions, missing and incomplete data, sweat, sensor artifacts, sensors popping off, and more. And when we think about all of the different kinds of patients out there and all the different possible sources of variability, one can imagine that it may be very difficult or even impossible to take a if-then, a purely hand-coded approach to capturing all of that natural variability we see in the real world in human physiologic data that we collect. Now, in contrast to a hand-coded approach, we apply a technology we call Waveform AI. We call it Waveform AI because some of the most popular forms of data to utilize for artificial intelligence, probably the two most, would be images and text. So there are a lot of algorithms that have been specifically designed, set up, and optimized to be able to work on that kind of image data for things like visual object recognition and object classification, as well as that text data with natural language processing and speech-to-text translation. Waveforms in the AI world on a comparative basis feel like they are at least about 5 years behind the developments and the progress that's occurred with images and with text. Now, why is that? When we think about waveform data, sleep study data, for example, it's even more heavily unstructured than image and text data. It's arbitrary in length. We don't know how long it will be in advance. It includes multiple modalities of data with different electrical characteristics and different sampling rates. And it includes tremendous variability between patients. So in order to handle this kind of unstructured data, special AI methods are needed to deliver generalizable, accurate performance for a broad class of patients in the general population. Based on this, Waveform AI represents a compelling tool set and technology to approach the problem of developing AI sleep scoring technology. Now, bringing it all together, AI scoring commonly then is a waveform AI technology applied to sleep scoring. It automates event detection, physiologic pattern recognition, and analysis of in-clinic PSG data and at-home HST data with the initial analysis performed by that AI scoring software. The AI analyzes the data, and that data is reviewed by expert clinicians. The goal in doing so is simply to improve overall patient access, to contribute to greater efficiency and scalability of care, and to enable more undiagnosed patients to receive this treatment that could transform their outcomes and their quality of care. Now, so far we've provided a definition of AI scoring, and we'd like to conclude with some clinical validation evidence. Now, in general, clinical performance validation studies and evidence have been somewhat limited for the application of AI in sleep and in healthcare more broadly so far. And so this data that we'd like to share includes one of the largest clinical performance validation studies that's been done so far in artificial intelligence for the application of sleep scoring. And it involved 3 different clinical validation study samples with 2 adult samples and 1 pediatric sample. Now, to clinically validate the performance of an AI scoring tool, we utilize these 3 diverse, representative, and de-identified clinical study samples that included patients from a broad set of the disease spectrum, from 4 different sleep apnea disease state severity quantiles, including normal, mild, moderate, and severe sleep apnea patients, patients from 7 different relevant and confounding medical condition groups of interest, many of those key comorbidities that we're interested in sleep apnea's influence on. That includes other sleep disorders, psychiatric disorders, neurologic disorders, neurodevelopmental disorders, cardiac, pulmonary, metabolic, and other disorders as well. It included patients from 5 different groups of medications that can potentially confound sleep and sleep quality as observed in data that included benzodiazepines, antidepressants, stimulants, opiates, and sleep aids. And finally, patients from a broad class of different demographic groups, from all sexes, all ages, all pediatric groups, BMI groups, sleepiness groups, and more. So in total, this study involved these 3 different 100 patient samples for 300 studies in total that were each scored by 3 double-blinded RPSGTs from a panel of 9 expert scorers to construct a 2/3 majority, a consensus-based scoring reference for comparison of the AI. In total, a grand total of 900 sleep studies that were individually scored across all 3 samples. Now, using these samples, the performance was clinically validated specifically for 20 different individual event types across 6 different AHI thresholds, and this included 6 sleep staging experiments, 11 scoring events, and 3 physiologic analyses and event types, as well as 6 AHI subgroups and AHI in REM and during non-REM sleep. We compared the results from a tech standpoint to the prior published EnsoSleep clinical validation performance results from 2017. So how did it do? Here on the slide, we have the demographic information and distributions from the patients in the bottom left. On the top right, AHI severity, and then the bottom right, the total sleep time. Overall, the AI performance did well. We observed 93% and 95% agreement, respectively, for the AHI in recognizing patients in the mild and moderate OSA groups. In pediatric patients, we observed 93, 95, 85, and 90% overall agreement for AHI in pediatric groups of 1, 5, 10, and 15 AHI thresholds. And finally, in looking at the total sleep time, the denominator that goes into the apnea-hypopnea index calculation, a parameter that is important for accurate and correct diagnosis, we observed an average difference of less than 6 minutes in the total sleep time when we compared the total sleep time estimate from the AI scoring to that of the consensus panel. So those are the high-level stats, and we'd like to pull back the onion one layer deeper to get some further insight into why it works so well. To do that, we'd like to look at 2 examples. First, Let's look at the AI scoring performance for analyzing EEG data, specifically depth of sleep and sleep stages on an epoch by epoch basis compared to the consensus reference. What we observed in this study was overall generalizable performance for being able to accurately determine the depth of sleep based on that EEG data using the AI scoring. We observed 86% overall agreement across all 5 sleep stages in the first adult cohort. Similarly, we observed substantially equivalent performance of 89% overall agreement across all 5 sleep stages in the pediatric cohort, showing that the AI performance is similar, independent of the patient's age, as well as the other demographic variables that we had collected. And finally, as a data point for external validity, we also validated the AI scoring on a second adult patient sample from a different set of facilities. This is important to help to understand the generalizability of the AI and specifically how well we can expect it to work in different locations and different kinds of data. In this third data set, we observed an overall agreement of 90% for sleep staging across all 5 sleep stages in adults. Based on this, we were able to validate both the consistency of that performance and the generalizability of the AI for a broad class of patients, from the youngest patients to the sickest patients that we see in sleep medicine. The second example is the application of this AI scoring to respiratory data commonly recorded in routine home sleep apnea testing. This second example demonstrates the opportunity for AI to assist with improving the reliability of home sleep apnea testing. And how we do this is pretty interesting. So to break it down, on the left, what we have is pulse rate data that's collected from the PPG, the photoplethysmogram. Now, this is the basic signal and sensor input and modality that's utilized to calculate the SpO2 or the blood oxygen desaturation levels that we use to tag 3-4% or greater desaturations. In addition to the standard output of this SpO2 level, we've added several new and novel outputs that one can accurately estimate and calculate from that input PPG on the left. That includes 3 things. First, the ability to estimate respiratory rate. Some have called the neglected vital from the PPG. In doing this, we clinically validated the ability to get over 90% of our epochs within 2 breaths per minute of the expert scoring consensus for respiratory rate. Now, it's been called the neglected vital because it is not routinely recorded in all monitoring scenarios, but when its values are very high, say in the high 20s or very low, in the low 10s, that can be a sign of critical illness in patients when observed. Second, to provide greater depth and breadth from the PPG data, we've also enabled the ability to measure, monitor, and estimate depth of sleep from this respiratory input data. We clinically validated and measured that performance in 2 different ways. First was by looking at epoch by epoch sleep versus wake stage agreement when the AI analyzed the respiratory data in comparison to the panel of experts analyzing the EEG data. On an epoch by epoch basis, we observed an agreement of over 90% for that sleep versus wake determination. That epoch by epoch scoring is fed into the TST calculation. And impactfully there, we observed a mean difference of less than 6 minutes compared to that gold standard consensus total sleep time determination based on the PSG. Now, why is this important? Well, the apnea hypopnea index, as we mentioned earlier, is a calculation that's numerated by the number of sleep disordered breathing events, but it is kind of denominated by the total sleep time. In that sense, the total sleep time can have as big of an influence over the patient's ultimate diagnosis and OSA severity as the top part of that fraction can. And based on the standard ability to recognize this depth of sleep in EEG data, which is absent from home sleep apnea testing, this presents a unique challenge, both for human visual pattern recognition, as well as for classical auto scoring technology and approaches. So this is another example of the promising application of Waveform AI to assist with scoring and the ability to create new outputs from some of the data that we're the most familiar with. Finally, I'd like to conclude with a recap of the key takeaways for each of our major learning objectives, as well as some closing remarks. So, OSA, sleep apnea, is an undiagnosed public health crisis today, which plays a major role in patient health outcomes like mortality and survival, quality of life, and cost of care. This effect is particularly so in patients with chronic comorbid conditions, and it's no surprise. Sleep is the third leg of stool of health and wellness, along with diet and exercise. When you look at the prevalence of OSA in relation to these chronic comorbid conditions, sleep apnea is consistently at the scene of the crime. But the good news is that there is tremendous clinical evidence supporting the effectiveness of therapy in OSA for significantly improving patient outcomes and overall health. That artificial intelligence is a subfield of computer science with its roots back in the 1950s that's rapidly grown in provenance and has achieved superhuman accuracy and performance in a variety of tasks that involve games, images, and text data. That machine learning is the most popular tool in the broader AI toolbox that's well suited to supporting complex problems with the variability, volume, and veracity of real-world data that we see, especially in healthcare. That the recent developments in deep learning models for large data sets have further built upon these performance breakthroughs. There are numerous examples of AI and machine learning in healthcare broadly and in sleep specifically, with demonstrated promise to help answer a range of basic scientific questions about sleep and some of the greatest challenges in the clinical practice of sleep medicine and patient care today. That AI and machine learning finds natural applications in clinical sleep medicine, given the size of the undiagnosed sleep apnea population, the limited availability of healthcare resources, and the massive impact and benefit therapy can bring to patients that need help. How Waveform AI enables a fundamentally different approach to the development of AI scoring technology that's in contrast to prior if-then systems that struggled with the tremendous variability that we see in real-world data. And finally, observations and key takeaways from one of the largest clinical performance validation studies performed on AI scoring to date that demonstrated consistent, generalizable, and accurate performance for a broad class of patients, from pediatrics to adults, from multiple sites and the sickest patients. I think that this topic is tremendously exciting, as sleep is an inherently interdisciplinary and multidisciplinary field, and that mirrors AI too. Through partnership between clinical sleep medicine and AI and machine learning research, we can create and use a new and powerful set of tools to reveal a deeper understanding of the true nature of sleep, its role and its influence on human health and disease, and how we can continue to evolve patient care to create greater access to diagnosis and treatment that can transform not only an individual patient lives, but the multi-generational impact of sleep, the lives of their families, their loved ones, and their communities as well, that they bring their energy to every day. Thank you for listening, and I'm excited to take your questions as well. On to the next talk. Thank you again.
Thank you, Chris. I feel like I learn something new every time I hear you present. Don't forget, everybody, we will have Q&A at the end, so keep writing those questions down. Andrea, I'm going to hand things over to you.
Thank you so much, Chris, for that insightful view into AI in healthcare. My name is Andrea Ramberg. I'm going to be talking to you about the expanding role of the sleep technologist. So when we look at sleep technology and the sleep field in general, I mean, those of us that have been in there for a while see how much it's changed and see how much has been brought into our field and how many other medical disciplines are starting to be interested in sleep and how they're seeing it tying into what they're doing with their patients. You know, but the concept of change can be kind of hard for a lot of people. You know, it's how do we facilitate that change and how do we create that in our field to where we are prepared for a change and our staff and our employees and everybody around us is prepared for that change. And it becomes important to keep up with all of this change, because if we keep doing things the way we're always doing, we're not going to catch up with all these new technologies. Sleep is not going to be able to have that space. And I believe in creating that concept of change to where we can really go into this next level. So there's, when you think about why people resist change, there's, 7 big reasons why when I work with sleep technologists, that they're like, hey, this isn't cool. Like I'm really scared. I'm really nervous about what's happening. And one of the, main reasons is there's a lack of clarity and fear of the unknown. The tech is like, what will happen to my job with all these technology advances? You're bringing in HST units and AI scoring and different things along those lines. And techs are like, I don't want to lose my job. I was trained to do this certain role. And here you're bringing in something that's going to shift how I do things. Does that mean that I'm going to lose my job? And there's this the fear of like a lack of skills that they're to do it. Do I know how to do this new thing? I mean, will I understand how to do it? I wasn't given that training. I think in school, so much of what we were taught is definitely more of the old school way of doing things. And as we're advancing, some of it is, taking a step back and making sure that you have that skill set. And then there's a overcommitment to the current model and a change to your routine. I think we all have our routines. I have my morning cup of coffee that I always drink. And, we get into the routine of everything. You go into your job and it becomes like clockwork. As a scoring tech that comes in, they're used to coming in and clicking their study open and going through it. And it takes a different framework to help shift, of their routine. And there's this lack of trust. I hear from techs all the time, hey, I put my name on this study, and when that physician comes back, I can feel confident that I did everything I could, that I did my job right. And if you have something like the AI scoring coming in, they're like, can I even trust this to do what it needs to do? Is it me? Is it, all of that? And what I always go through with techs is it still is your name on it, and it's still, you can make any change that you want with it. I like to see it as a tool that helps them get through it faster, and almost like a coworker or like somebody else that, when you're reviewing the study of your favorite person that has scored that study, right? We all have those techs where they're right on the ball and you love getting their studies because it's pretty neat and clean. And think of it like that. It's not a matter of thinking it's going to do a bad job or that you don't want to put your name on it. It's trusting it and learning to trust it to where it's like, hey, I know this has got my back, right? Like it's going to make me a better tech. Being left out, I hear techs talk to me all the time saying, this affects my day-to-day. Why wasn't I even brought into this decision? Why wasn't I asked what I thought with it? And then there's this resignation or perception of change. So just because a tech is going along with it, just because we are going along with it, with the changes, doesn't mean that we like it. Doesn't mean that we want to say, hey, let's shout to the rooftops, this is great. We go along with it because we love what we do and we want to help our patients, but we might not fully accept it. And some of what I like to do with techs is to help get over that hurdle and to help accept it. And then there's also this concept of the inadequate benefits and rewards. Is this really going to do what I need it to do? Okay, fine, it's helping me, but is it helping me enough, right? And so I think some of that, when you're looking at impacting change in your organization or adding these different roles for these sleep techs, it's important to take a step back as a leader, as anybody really, when you're trying to change your life, is to say, okay, what are the hurdles and what is going on underneath it all, and how can I address this to help that, to facilitate this a little bit better? We have seen everything moving towards the future, as I mentioned, and as with Chris's presentation, all the cool things that we're able to do now with technology, and it's we're seeing how it's changing and advancing and all that. But technology is also doing really cool things, really good things, right? It's increasing access to care, improving outcomes, and enhancing patient and physician satisfaction, while at the same time reducing costs. So we're seeing this access to home sleep testing and in the home, and all the AI that's going to help us facilitate a faster diagnosis and all that. And we need to make sure that we have a foot in the door with it. On the clinical side of things, I'm very passionate about making sure that we have that clinical validity with it all and that we're doing still the right thing for our patients. And I think the merging of the two worlds, I think with our voices, with the clinical side of things and the technology, I think we really have a great opportunity, to bring this into the future. I gotta laugh at that face because I feel like when I first came into this, with the technology and when I first started learning about it, I was like, what is happening? I always had to have them I was always one raising my hand saying, I don't understand that. Can you explain that again? Or, I was never that tech savvy. This is gonna date me a lot. But back in the day, I mean, I didn't have a cell phone in school. Like I had the old dial-up internet to where someone would bound to be kicking you off if they had to use the phone. And it's the same concept of technology as we're looking at this stuff, as we're, it's normal to kind of feel like, hey, this is way over my head. Even those that consider themselves tech savvy, I think it's still, in the sleep world, I think there still needs to be a lot done to help bridge the gap between it, bridge the gap between what us as clinicians were taught and then what technology is where that's taking us. But, I always say that what technology cannot give is that human touch, right? It's what we're doing as sleep clinicians. We are the patient care. We are the ones that giving the empathy. We're the ones that can read a patient's body language and their facial expressions and all of that in a way that AI can't. As you're reviewing a sleep study and okay, the AI has predicted, what stage of sleep and events and it does that really well. But I've heard techs like, okay, but look at the bigger picture with with the patient. What is that patient doing? And I bet that patient is, going in and out of congestive heart failure or just different fluid overload or just different things like that you can tell within a sleep study that is important to note for that physician, the different arrhythmias that they're having. But AI might not be able to pick that up, right? And so I think when we think about that human touch and what is still needed for our patient base, that's our clinicians. We as clinicians can really make that impact and to not only help the patients, but educate our communities and educate everyone around us that this is something that's really important. And I see this facilitating different roles within it. So how do we, as sleep technologists, make our mark with that? And how do we advance this? And where can we insert ourselves to really help facilitate all of this and help transition from where we are today to the future of sleep medicine? And I really see the CCSH is facilitating that. And I highlighted these words because I feel like this is exactly where health medicine, sleep medicine everywhere is going now. The coordination, managing, improving outcomes, educating, and advocating. And that's something that I think each and every one of you do on a day-to-day basis with your patients. It might not be the formalized program of what we're doing, but it's what you do. You advocate for sleep, and I don't know about you, but whenever I go out, I get asked about sleep all the time whenever they find out what field I'm in, and I don't think that's any different for everybody here. And where I am seeing the most need is these areas that they may kind of know about sleep, but they have no idea what it means to their patient base. They have no idea how to take it to that next level. So when, the CCSH credential came about, when I say it first came out in 2015, because us in the field, we wanted to create this next step for our field. We wanted to create this credential that helped individuals get that next level training that they needed to help facilitate these type of roles. So, I wanted to highlight real quick the different pathways to get your CCSH. There is 3 different pathways. The first one is clinical experience, 1,000 hours of experience in clinical health and a bachelor's degree or above. The second pathway is a healthcare credential. So something that we see a lot of is other healthcare credentials that are looking in the airway a lot. So for example, dental hygienists can sit through pathway 2. And with all their experience, they know, they can pinpoint it, but with this credential, it makes sure that they have those basics there. As a sleep technologist, I think we're taught a different pathway and all of that, and we learn all this stuff in and out. And what this does is it ensures that the other healthcare credential, that they know, that they know what they're doing with these patients and the stuff that they have to study and all that in order to be successful with it. And then we opened up a third pathway. And what this is you have to have a certain education STAR designated program that you go through, and you're able to hold your RPSGT and renew it at least once, and then you could sit for this pathway. And this was really to enable the sleep technologists. Yes, we see it as an advanced credential, and we believe in the higher education needed. But there's so many of you out there that really know what you're doing, and this allows us to make sure that we're helping you get to this next level. So important roles that I see for this CCSH credential, a lot of it is, okay, I love the idea of this credential, but how do I use it, right? And what do I facilitate this? What programs can I start with this? Who is doing what with it? And I see 3 key roles as being the perfect for the CCSH credential and helping to facilitate this. There's something we call a sleep navigator, a sleep educator, and then a sleep coach. So the sleep navigator, it's this individual I see as being in a hospital system. They're the ones that are navigating that continuum of care. So they're helping to identify this patient population. They're helping to educate, and they're helping to get them plan that right care path for them. Do they need a home sleep study unit, or are they needing an in-lab study? Are they, maybe just non-compliant on their machine and they need some help getting back on therapy? There's a bunch of different avenues in which I see this facilitating. This is just one such one that was recently published in Sleep Review. But as you see these coming out more and more, it becomes important to show that data with it and to show the sheer number of patients that you are flagged at risk. The programs that I would help start across the nation, we had this rule of thumb of roughly 25 to 35% across the board would have sleep apnea or at risk. So what I would suggest is you take the monthly admits and then you divide that by, the 25%, and that's roughly the amount of patients that you can expect to be flagged at high risk for it. And the coolest part was it was consistent. It was no matter what hospital system I went to, no matter where I started this program at, they consistently were finding that number. And what always blew my mind in these programs is how little the other medical disciplines even knew about it. I would hear, what does sleep have to do with what I'm doing with my patient in the inpatient world? They can take care of that as an outpatient, and they can, but having that face-to-face time with that patient to educate and all of that, and to make other medical staff aware of it, could have been a difference between them getting treated and not. If they're not getting talked to when they're outpatient, what's the point, right? So this is a good time to have that face-to-face with them. And these are, a bunch of different programs too that I have consulted with, or just different things of, doing really cool things. And each of these programs, they operate slightly different, and it's important to create a program that works best for your hospital system or your area. There's no one right way to do it, as long as you are identifying, educating, and creating that care plan. Really, there's multiple ways in which you can do it. I would suggest working with, a champion in the hospital system. So whether that's your medical director, a physician, a nursing director. I work closely with nursing. They're the ones that are dealing with these patients around the clock. And, what can they do to help facilitate this, and where is the need for it? Where can you go in and maybe pilot it and say, hey, I know this is a new program, but give me 6 months with this certain pod, maybe the cardiology pod, and let's see what we can do, with it. So another cool role that has come out of this credential is a sleep educator. And where I see this sleep educator functioning is in the outpatient setting. So Is it, the DME settings, or maybe they're the ones that are seeing that patient between having a home sleep study unit done and then getting set up. And so as we see other medical disciplines navigating this and helping to diagnose patients, how can we still ensure that that patient stays compliant and buying into their therapy? As most of you know, just because we diagnose a patient doesn't mean they're going to use the CPAP or even other alternative therapies like oral appliances or, all the different things, that options that they have. And part of our role is educating them on that they're how to use it, tips and tricks, stuff like that, but B, also that there are other options, and helping funnel them into the right option can be super important for them to buy into their, their therapy and to their treatment plan. And, it helps see and function within other offices too. I have CCSHs that work in cardiology offices. I have CCSHs that work in dental offices. It's that concept of that education point that we have with those patients that only we know, right? Like, we know front to end what we're doing with those patients, and we have a unique role in this, and to be able to identify that and to put ourselves into areas of need. The sheer amount of people that are still undiagnosed is crazy to me, because we could see it wherever we go. It's super easy for us to spot, and the risk factors and all of that. So what I challenge technologists is, where do you see the need in your community? Let's start creating these new programs. Let's start figuring this out, because the need is there, and other individuals and other medical disciplines are starting to, get that freedom to order HST units and get that patient educated. But why not help them with that? Why not act as like a physician extender, in a sense of helping them get these patients diagnosed and helping them educate and all of that. And then, the third one that has really just come, I think, probably in the last 3-4 years of, coming out as a thing, is sleep coaching. So where I see sleep coaching is, it's a little more on the behavioral side of things. I just did a conference with this Behavioral Sleep Medicine Society in Nashville, and it was really cool to be working so closely with the sleep psychologists and the physicians and all of that, to be able to create that, to figure out what to do with these patients and how to help them and where they need the help and all of it. So what a sleep coach is doing is helping them to focus on the behavioral patterns. So what intrinsic motivation do they even have to change their sleep, like all their issues with their medical health, stuff like that. But it's really important to know that we cannot do it alone. It takes a team with this, and it is not CBT or therapy or counseling. You should never do anything with recommending changing medicine or anything like that. But it does function. You can approach their physician and say, hey, this is what as I'm going through their sleep diary or the different, parameters or tools that you're using with that patient, I'm noticing this, hey, they're using 3 different types of sleeping aids and they're mixing this medicine, stuff like that. What do you think? Or where should we go with this? And let that physician handle that component with it. But a lot of that in-depth work that you're doing with that patient, that sleep psychologist or that physician, they just don't have the bandwidth to do an hour with that patient when they're on a strict schedule with it. So where I see this role is, it's really helping to facilitate not only like the extension of the physician, but it's helping to facilitate more of a proactive approach to sleep health, instead of us catching these patients at the end after they've had their heart attack, after they've had their stroke. This role I really see as being, well, how can we be proactive before all those things happen? How can we help spread sleep health all over, right? And to help educate and all of that. So with all these roles, I get it that a lot of it is very new, and maybe there's a lot of different hurdles to getting them started. But when I see such advances in sleep technology, with the AI scoring, it's part of what I love to do is say, hey, now that we've freed up this time for you, you're not spending 8 hours a day scoring a study or you're spending maybe like 3, with that massive amount of studies that you have to get through. And then let's see what else we can do with your time. Let's see what else we can do to start these programs. It's, I don't have time. You're stretched thin, and, and with all the challenges that we've had in sleep medicine the last couple of years, it's how can we help facilitate that, and how can we help move sleep technology into the future to be ready for these technological advances, right? And so we feel safe and secure in our jobs, in our roles, and to take sleep medicine into the future. Thank you.
Thank you, Andrea. I mean, how lucky are we to have her on our team, right? Okay, now it's my turn with the shortest section, where I will cover how EnsoSleep AI-assisted sleep scoring can help overcome some of today's greatest challenges in sleep medicine. The overview, challenges in sleep medicine, overcoming some of those challenges, and then a demo of EnsoSleep. Healthcare is changing. In healthcare, we're continually being asked to do more. I know there are long wait lines. I know patients have really high expectations. In lab, patient complexity is growing. As I mentioned, those wait times for the level 1 studies continue to grow. This puts additional stress on staff, right? The sleep physicians needing to get to all of the studies that need to be done, sleep techs being able to review all of those studies, trying to get to as many patients as possible. I know in the United States and in Canada, there's a shortage of technicians, there's a shortage of sleep physicians, and unfortunately for sleep apnea patients, the volume of patients and the potential patients that need our help continues to grow. So there's certainly a disconnect there. And then with patient expectations, there is that request, not only because of COVID. I think as technology has been evolving and patients who are also consumers in the world and expect to be able to have things immediately, naturally people were already leaning to have more remote access to care, but then COVID obviously exacerbated that as well. So the sleep care continuum and what does it look like? A lot of the things that Andrea covered are areas where sleep technologists can really embrace the role of additional items in the sleep care continuum. Obviously promoting awareness from creating referral networks, making sure that patients are aware, attending job fairs. I won't spend too much time on all of this because I know Andrea covered most of it, but really creating that awareness to make sure that we're getting to as many patients as possible. Potentially screening those patients, as mentioned, with like a sleep navigator role, and making sure that we can flag things with stop bang and whatnot. And then the testing. This is where we are really able to address with EnsoSleep the need for the volume of testing and getting that testing done and then scored and then to the provider to give the diagnosis to a patient. So really where we're able to assist is in this area right here of testing. Continuing in the sleep care, the diagnosis, getting an answer to the patient, getting them treated, some sort of a resolution for them, and then adherence, whether they're doing CPAP, whether they're doing some sort of an oral appliance, making sure that we have the right fit for them and having the time to be able to follow up with them. So with that, I want to talk a little bit about how we believe EnsoSleep will be able to help solve some of those stresses, in particular that are sitting on the sleep labs or the dentistry offices in Canada. EnsoSleep at a glance. EnsoSleep's AI-assisted sleep scoring enables a technologist to edit the study rather than score it from scratch, okay? So think of it as overscoring. We could do the first pass with the EnsoSleep artificial intelligence. So you would run the study like you would a level 1 or an at-home sleep study in lab or at home. The EnsoSleep software would then take that study and provide the score, and then the technologist or the provider would simply review the results, come up with a diagnosis and the conclusion, make any edits as needed. I know, especially in the level 1 studies, technologists are going to be able to catch things that artificial intelligence just isn't. So having somebody take a look at those studies, making the changes and then getting the results to the patient very quickly. Typically, we find up to a 75% reduction in reviewing the studies by allowing the technologist or the provider to simply overscore versus having to score the entire study from scratch. Something that I think is also very important to point out here is that EnsoSleep is compatible with all or most major viewing and software systems. So it runs in the background. If you look at this image over here to the right of the screen, running the test, having it show up in your current software, whatever equipment that you're using, when the study is complete, the software or the study gets pushed to EnsoSleep. I'll show you a couple of examples of that in the demo, which comes next. EnsoSleep scores that study and then pushes it back down to the viewing software or the device software that you have in your office or your clinic to take a look at it and then make any adjustments and then provide the diagnosis for the patient. I just want to remind everybody it does work on level 1 in-lab studies, the PSGs, as well as the home sleep studies, the HSTs. Okay, let's take a look at EnsoSleep. Okay, first thing that we want to take a look at is the workflow with Cadwell. So you will see we have a direct integration for anybody using the Cadwell devices and the Cadwell software. We're obviously not going to have time to cover all of the different options, but I picked a couple just so that you could get an idea of how seamless it works into the workflow. This is something that I'm not going to speak through much. There is a description on the video itself. It's just over a minute long, so it doesn't take very long. But if you are able to see the screen, it'll help you understand the workflow. Here we go. So you can see how awesome it is that the integration is direct with Cadwell. There's no manual moving the studies around or anything that you need to do. We do show the viewer of EnsoData here as well as the Cadwell view. Most people don't necessarily need to look at the EnsoData, EnsoSleep viewer because everything just shows up in Cadwell, but the double screen gives you an opportunity to see both and kind of what's happening in the background. And it just shows up. And there you go. You can see the scored study ready for you to review and make any edits. Now we're going to take a look at the native Sandman software and how that workflow fits into your practice. Okay, in Sandman, I do not have words written out, so you get to have me narrating. And again, this video is just about a minute. So you can see you open the Sandman software. We're going to scan for all media. Once we do a scan, we can see any new studies that were completed last night. So we have a study for Remy as our example patient. So we're going to move Remy's unscored but complete study to a new folder. And then we're going to start it. We're going to do the same thing here that we did at Cadwell. We're going to close Sandman and just go to the EnsoData viewer. You do not have to use the EnsoData viewer, but you can see now that it's been put into that additional folder, EnsoData automatically grabs the study, scores it, and then lets us know it's complete. The workflow in your office might be the morning techs come in, drag the studies over, get a cup of coffee. By the time they get back, the studies will be scored. You don't have to look at the viewer. You could just sit down at Sandman and scan again. And now you're going to see in the scored studies, Remy's study is done. EnsoData has pushed that study back. So now we click on Remy, we hit edit, and it's going to pull up the scored study. Again, allowing a technician to get in here and make those edits, review anything, see if there's anything going on, and make any changes that are needed. Okay. Finally, the last little bit I want to show, just because I don't know the other software all that well to show how easy it is to edit or what a completely finished study looks like, but we do have our own viewer, like I said, something that you probably won't need to use, but if it is something that you're interested in, if you don't have software that you love, it is something that you could also talk to us about. But I'm going to go ahead and just open up a study just to give you an idea of how quickly EnsoData goes in, scores that study. There's obviously, this patient is awake. One of the settings that we have for you to be able to toggle and configure based on your practice is to not score during wake, which is what I have it set up. So there's no findings here during wake. But if we scoot forward a little bit, you can see a scored study. So imagine this now in your viewing software, okay? You have the ability to come in here and make any adjustments. You could delete things if things need to be moved, if things need to be shortened, if the stage needs to be changed. Don't spend too much time looking at the EnsoData viewer, or the EnsoSleep viewer, which we are happy to talk to you about if you have a bunch of different devices and you would like to have everything in one place. However, if you can imagine how this looks in your software coming into a study, whether it's a level 1 in lab or it's something that the patient did at home, and having the study scored, having all of the results that you need, reviewing it here, generating that report, and getting the diagnosis out the door to the patient. Hopefully allowing the staff to do all of those wonderful additional things that they could do, your RPSGTs for the patient that Andrea discussed, maybe shortening that wait time to get patients in to see people and really address this very important condition of sleep apnea. So with that, we're going to end the recorded part of the presentation and open it up for Q&A. Hopefully you guys have got a lot of questions for us ready.